Good morning. This week I'm doing my week 2 assignment on my case study. My name is Erica Di Benedictus. So, patient Mr. Jones is 92 years old with acute congenital heart failure. At this hospital, he was discussing with his family members, the healthcare provider, and they decided not to resuscitate at the first day of hospitalization. The son did. On day 3, when the patient became hospitalized, the daughter of the patient came to the hospital from out of town, and she had a durable medical power of attorney. And she decided to state that she had it and to cancel the DNR and to resuscitate him as needed. And the hospital scanned the documents into the EHR system. And originally, there was a portion for DNR orders in the EHR system, but that stated that he did have a DNR, but that was not changed. So each day the patient was hospitalized, the hospital did not continue to not change that part. They just decided to copy and paste in the note section that he had a DNR. The patient, like many families, the son and daughter disagreed with the decision. He thought because he was a nurse and had the professional background and education that he had the best decision-making skills. So by day 5, the patient began to deteriorate, and he went into cardiac arrest, and a code blue was called. The medical team began to resuscitate. However, the unit clerk ended up coming in saying the patient was DNR, so they stopped resuscitation, and the patient ended up dying. So as director of risk management, I was approached by the CMO, and there was possible medical malpractice claims, DNR documentation issues, and the disagreement between the son and daughter. So when we look at the root causes of the process at the legal standpoint, there are several issues. There was the failure to update the DNR order, the inadequate documentation practices, a communication breakdown, and misinterpretation of DNR status. Now, the issue with the failure to update the DNR order is that when the daughter arrived, they did scan the documents and she asked to remove the DNR. But unfortunately, that wasn't reflected properly in the EHR system. It wasn't in the correct section. It was only in the notes, and this created confusion and inconsistency in the patient's treatment plan. Excuse me. There was also inadequate documentation practices. Even though the daughter requested to cancel the DNR, and the hospital did, in fact, scan the relevant documents into the AHR system, the portion which was relevant and the most important part of the DNR order in the EHR system was not updated. Rather that, the medical staff just continued to copy and paste in the notes section, which wasn't the accurate area to update that. I recognize. There was also communication breakdown. This is not only between family members, but also medical staff and hospital administration. Even if it's in the EHR system, even if there is changes, there was still a communication breakdown. The medical staff should have came together and discussed, and that would have maybe changed the outcome. Also, the misinterpretation of the DNR status. There was confusion around the patient's DNR, and unfortunately that led to a failure during the code blue. Even though they began to resuscitate, the unit's clerk announcement stated that the patient was DNR, and that's what resulted in the resuscitation efforts being stopped. So this could be viewed as a breach of standard in medical practice. All these causes suggest potential liabilities in medical malpractice, including negligence, failure to properly document, communicate treatment decisions, and failure to adhere to established protocols. The legal foundation of consent to treat and DNRs in the state of Connecticut are somewhat significant. In the state of Connecticut, if a family member holds a valid healthcare power of attorney, they have the authority to make medical decisions on behalf of the hospitalized patient, including any decisions about DNR orders. At the time of the decision, there was no indication that the patient had a POA with the DNR wishes, and the family members that were present there were legally able to make a decision at that point. it wasn't until the daughter came 3 days later that they realized there was a POA, and that's when they had to legally adhere to that document. Regarding validation in Connecticut, a DNR order must be signed by a physician and remain on file for the order to be valid. Regarding documentation and information, Connecticut law does not require hospitals to put signage in hospital rooms with DNR notification, and it only requires it to be recorded in medical records and the EHR system. In many other states, sometimes if you go into a hospital room or even outside of the hospital room, it says DNR, so that is not the case in Connecticut. In Connecticut, a healthcare provider or healthcare institution that is furnished with a copy of a written living will or POA must make it part of the patient's medical record and also keep it on record any oral communications concerning the patient's healthcare. In Connecticut, according to Connecticut General Statute 19A 5080D6, when an attending physician issues a DNR, the designated agency which provides the DNR bracelets must be contacted. And if a patient is unable to obtain a DNR bracelet, the attending physician must provide one. And that's coming from the Connecticut Department of Public Health. Once a DNR is revoked, the bracelet must be removed and a statement must be entered in the patient's permanent medical record and notify the attending physician. Now, obviously, that wasn't the case in the scene. If it was Connecticut, he would have had a bracelet at a time when he went into cardiac arrest. If the, I'm sorry, I have a cold. At the time of the cardiac arrest, the patient would have had the bracelet removed, and that may have seized the confusion because they would have seen that the bracelet was off, that he was in fact not DNR, and they could have continued to try to save him. When it comes to this case and the electronic healthcare record, there was the inadequate updating of DNR status. Even though the daughter's request to cancel the DNR order when providing the POA of the patient and the documents were scanning into the EHR system, the portion of the EHR system which was relevant to the change of the DNR order was not updated. The failure to update the patient's DNR status in the EHR is what led to the confusion and conflicting information between healthcare providers and ultimately led to the patient's resuscitation during the Code Blue event. And that's what caused them to stop because they were told there was a DNR. There are also communication challenges. Even though the EHR system, the purpose is facilitating information for healthcare providers to access, it still should not replace direct communication between individuals. There was obviously a clear breakdown in communication between the daughter who requested the cancellation of the DNR and the healthcare team that was actually responsible for updating the patient's records correctly. The inappropriate use of copy and paste. This is what is really important to me because the same order for the DNR was simply copy and pasted into the EHR note system each day when the patient was hospitalized. This creates errors and inconsistencies in documentations, especially if changes in the patient's treatment plan are not accurately reflected. This contributed to the failure to update the patient's DNR status and the healthcare providers that still thought the DNR was in place. And it could have been in place because they looked at the section of the DNR order and not the notes section. In addition, Connecticut law requires a DNR bracelet. If the DNR was still in place, a bracelet would have been on the patient, and that would have made it easier for the healthcare providers to determine a DNR was put in place. But since bracelet was not on the patient, if this were in Connecticut, it would be safe to say that the DNR was not in place, as I mentioned. The process to legally validate and document consent to treat durable medical power of attorneys in a DNR would be to first identify the patient's POA and confirm the existence of it, assess the patient's medical condition and prognosis by evaluating the patient's medical condition, prognosis, and treatment options to help inform decision-making, ensure proper documentation. As mentioned, once the POA and DNR documents are completed, they must ensure and promptly document in the patient's medical records and scan into the EHR system and update the relevant sections. And then the communication of treatment preferences. This way that preferences include the DNR order, and they're also all communicated to relevant healthcare providers orally and on the system. When looking at legal recommendations, it's important to regularly review and update the DNR orders. They should implement protocols and regularly review the DNR orders, especially when there are changes. Continue to ensure healthcare providers are trained to use up and update the DNR orders in the EHR system and properly change them when changes are made. Also, enhance documentation practices by developing standardized documentation procedures for DNR orders and also including clear guidelines for documenting changes or updates in the EHR system. They should also require providers to document any oral discussions or decisions related to treatment preferences. Also, the importance to improve communication protocols. Establish clear communication channels between providers, patients, and family members, and authorize representatives regarding treatment decisions and changes in DNR status. Also, it's important to ensure healthcare staff receive training on effective communication strategies and how to address disagreements among family members regarding treatment decisions. Also, education and training. This is, it's important for healthcare providers to be provided with ongoing education and training to them on the legal and ethical considerations surrounding consent to treat DNR orders and advance directives. All for training should be focused on proper documentation practices, communication skills, and conflict resolution techniques. One of the most important recommendations is audit and quality improvement initiatives. Regular audits to be implemented or quality improvement initiatives to assess compliance with documentation protocols to help identify areas for improvement and address any gaps and deficiencies in the process as an effective way of mitigating EHR documentation integrity risks. And that's recommended by the Centers for Medicare and Medicaid Services. These audits could also use the findings to develop targeted interventions, update tech policies and procedures, and also help to reinforce the best practices related to consent and to treat DNR orders. Lastly is the integrate decisions to support tools in EHR. They could integrate decision support tools within the EHR system to help prompt healthcare providers to review and update DNR orders during any changes, and also utilize EHR alerts and reminders to notify providers of any upcoming DNR order expirations or the need for reassessing. By implementing these legal recommendations, healthcare organizations can improve their compliance with legal requirements, enhance patient safety, and mitigate the risk of errors or disputes related to consent to treat DNR orders. These measures contribute to more efficient, transparent, and patient-centered approach to end-of-life care decision-making. And that's about it with this presentation. Thank you.